There you go. Okay.
All right. Well, good evening, everybody. It's a pleasure that you all joined. Alhamdulillah, we're here for another session. I recognize that you've all had several sessions with the energetic Fatima and the excellent Dr. Rebecca, and so today you get me. Well, I'm neither of those two things, but inshallah we will try to make two. I'll say at the outset that my goal is to finish at 6:15, right around Maghrib time here for me, so that we won't be too delayed. But inshallah, we'll see how far we get. So today is, we're delving into the mosque context and stakeholders because all the framework that you've learned is going to be applied, or will be applied to this context. And my goal today is several forth, but I'll first want to do some preliminaries. I've learned that as part of this cohort's experience, we're starting to start each session with a prayer. So this is the one that was Saif had selected for us. I'll share my own in a second, but for those who want to stick to the slides, this dua is from, I think it's both in Bukhari and in other collections as well. And the dua is اللهم إني أسألك من علم لا تنفع وقلبا يخشع ونفسا ما لا يشبع ومن دعوة لا مستجاب لها. So this is the dua that says, "Oh God, I seek refuge from you, and knowledge that does not benefit, and from a heart that does not tremble, from a nafs that is not sated or is not contented, and from a dua that is not accepted." So may Allah accept this from us. Usually, when I teach, I teach from the duas that my teachers have taught us, and so when I start, I always go Alhamdulillah wa salatu wa salam ala Ali sabi mawala. اللهم علمنا بما ينفعنا وينفعنا بما تعلمنا وزدنا بفضلك العلم وتعليما إنك على كل شيء قدير. And that dua, as I said, is from one of my teachers, and it's one that's close to my heart. So the dua is not found in these narrations, but similar in content. So Allahumma alimna bima yanfa'una, oh Allah, cause us to benefit from what you have taught us, meaning that teaching and learning is not from ourselves, but rather it is passive, right, from Allah subhanahu wa ta'ala. علم لا ينفع Bismillah, it says and benefit us, so cause benefit for us from what we have learned or you have caused us to learn. And increase us in ilm, in knowledge. That's the third stanza, and then the fourth stanza is Oh Allah, you are the most, you have power and dominion over all things. So in any case, I would have had I had more time, I would have put that on this slide set, but inshallah, that's the dua that usually I recite when I start teaching. So with that, who am I? You all know this from our introductory sessions before, but I am the director of the Division of Islam Medicine, and I currently practice emergency medicine, and I'm vice chair of research and scholarship here at the Medical College of Wisconsin. All these titles are relevant for you, but anyway, I have those titles. What's more important is what we're going to talk about, so let's just move on and move forth. So inshallah, we're going to talk about Muslim American health outcomes research, and this is the larger scoping context of this project and the one that sort of preceded this one, the eMarch project. And you'll see that there are clear gaps in Muslim American health outcomes research, and we're trying to fill that in many ways, both in terms of a theoretical knowledge about how to think about these things and frame these things, and then also in terms of practical knowledge, how we can implement tools and toolkits, as this project that we're in here, and use methodologies to fill in these gaps. So that is a larger context. While you all and I and all of us are gathered here today, is to try to fill in these knowledge gaps around this domain. Today, as I mentioned, we're going to kind of delve into the Muslim American mosque context. So I'm going to present three things, really this notion of culture of health in the mosques, what's the present state, who the actors are in the mosque, who are meaning health agents, so to speak, and who the stakeholders are. All these sorts of things you all know, but the way I'm going to present it might be a little bit of different framing than you all used to. And this is a slide that you've probably seen from your prior work, or at least probably these lecture sessions that you've had around the idea that CDC has made national health priorities and a list of relevant populations. The social determinants of health is something that's been part and parcel of American healthcare delivery for 25 to 30 years. Trying to understand that the structuring of health in the society is not just the acute healthcare system that we're at, like the hospital I'm just sitting at right now, but rather health effects and impacts are much broader. And indeed, those in the healthcare system are the minority of what influences population health. This is also a slide making that more clear, that really is one sort of health behaviors and environment that play a huge role in individuals' life expectancy and the wellness that they carry with them. So I don't know how these questions were answered. These are slides that perhaps Fatima or Rebecca have introduced, and I will remind you that we're trying to think about that from a faith-based perspective. Similarly, we're launching out here at the grassroots level. You all will be embedded in mosque communities so that we can then produce data and insights that will then, inshallah, be disseminated, broadly speaking. So that said, this is kind of how I think about it. As I mentioned, that I am the director of Islamic medicine. We've been doing work for 9+ years. Fatima's on the board. We've had multiple projects on Muslim American health, and as you might know, on Islamic bioethics. And those are the two pillars of the work that we do. And our goal is to kind of fill in this box of ignorance. And in the context of Muslim American health, it's really these two things. The idea is that we want to move the known unknowns into the known knowns, and the unknown knowns into the known knowns. Now, as much as you all might like Rumsfeld, or perhaps you all have no idea who Rumsfeld was, and I'm dating myself, this idea here, I'm going to go through in our slide set and use it multiple times. So let me explain it to you for a second. Known knowns are what, as you see here in this idea, explicit knowledge. What is known to be true, what is known to be factual, what is known to be lived experience. It's just a known entity. And I'm saying that from the perspective of someone looking at Muslim American health. So if you think of yourself as an outside observer upon the Muslim American community, right, the known is what you have access to. I know Muslim Americans are XYZ million in the United States. So it's a factual knowledge, right? It's explicit, accessible. You have potentially no doubt about that. The known unknowns, again, from the perspective of an outside person, right? So the known knowns are those things which, the known unknowns are those things that we know we have knowledge gaps around. Right? So if I were to say, what is exactly the number of Muslim Americans in the United States as an observer, I know that that's an unknown quantity. There are many estimates, but the true number we don't know. Right? So from that observer's perspective, it's a known unknown. They know, it's explicitly known that there's a lot of variance around the population estimate of American Muslims. From the perspective of someone within the community, and I apologize for my phone, known unknowns are similar, right, but different. So in the sense that for us, what's a known unknown, if you're in the community, is that what my knowledge gap is, or what I don't know. Right? So just think from that perspective, that wherever that agent is, what that observer is, he or she, or if you want to speak broadly speaking, the healthcare system or the society, what is the knowledge gap for that entity? The unknown knowns are those things that, right, they're unknown in the sense that this is something. Now, let me use these two perspectives again. From the perspective of the community, right, if you're the community person, these are things that we know. They're known to us, but they're unknown to the external. Right. So, for example, religion plays a big impact upon health behaviors in the Muslim community. We would know that as an insider knowledge, right? But the external observer won't know. So for them, for us, this is the category of unknown known. It's a known to us, but it's unknown to them. Now, if you flip that around for the observer, right, what's an unknown known to them? Well, it's something that's unknown from the perspective of the observer, right? So for them, it's unknown, but it's unknown to someone else. So our idea here is that we want to move known unknowns, and you'll see throughout the slide, I'll go through this, and unknown knowns to the domain of known knowns. We want to make knowledge explicit. Both that is which is held by the community or lived by the community, as well as those known knowledge gaps by the external observer. So for my talk, what I'm trying to do is what we're trying to do, and what you will do in your project is trying to make things that are implicit within the community explicitly known, right, to the observer. And those things that you don't know and they don't know, you want to make them fill in those knowledge gaps. So there's two aims, dual aims. Now, in the Q&A, if you have questions about this, we'll get back to that. But I want you to, again, think about this and this idea that we are trying to move in the domain of Muslim American health, things to be explicit. Both the known knowledge gaps that the community has and the observer has, those knowledge gaps we want to fill in, as well as the fact that the community has some knowledge or has some experiences or has some understanding that might be known to the community but is unknown to the people outside. We want to make that explicit as well. All right, I hope that's at least somewhat clear. So let's start the talk, and we're going to start off with factual, explicit knowledge, things that we all know, but perhaps sometimes forget. And we'll start off with the idea of, as I mentioned, the Muslim American population. So we know that the American Muslim population is diverse, right? This is one caricature from 20 plus years ago, just a snapshot of Muslim Americans. They're a diverse group of different walks in life, different ethnicities, different sort of backgrounds. And we know that it's a growing and sizable population. The projections that we have from the best data is that the population will double by 2050. But I told you that there's some unknown idea, right? Some variance around what the population's numbers are. Now, I usually write in my papers between 3 and 5 million. Pew is on the lower end, so 3.45 million, and then you have some others like 2 million. But there was a review done by an academic of different sorts of things, and they sort of said that the average is around 5.4 million. So in any case, there's a variance to that number, but it's a sizable number nonetheless. And by the time 2050 rolls around, it'll have doubled. And we know that's diverse racially and ethnically. You can see here, and I apologize, I was on a shift, so I want to have some tea while I'm speaking. So you see here that there is some variance around what the number is of the population that is African American, South Asian, or Arab. But we know that these three groups are the larger racial ethnic groups in the community. And so that's why that's red. And so the diversity, we know that about 2/3, they say, are foreign born and about 1/3 are native. This number here is a little dated in the slide set. We know for the socioeconomic status that Muslim Americans are almost on par in terms of the higher group socioeconomically. So those who are in the 90th percentile, so to speak, are similar amongst Muslim Americans than Muslim Americans and the general population. But those on the lower scale, are more prevalent in the Muslim community, and that has been the case because of a lot of refugee populations that comprise of Muslim Americans, right? And that's been every decade. So if you think about back in the Iran and Iraq war, we had refugees here, then you had Somalia, then you had, and you've had Syria. So every sort of several years we've had, and unfortunately in the Muslim world, a lot of wars. So the United States is one of those countries up until now that's opened its doors to refugees, and Muslim Americans have been part of that group. We also know that a larger number than 5% of the youth physical workforce is Muslim, right? So we all talk about Muslims and the proclivity towards being in the healthcare field. Indeed, they are as you would say, an overrepresented minority in the healthcare workforce. And that most Muslim Americans are English literate. So only 90% English literate, which tells you the fact that when the character outside is that Muslim Americans are refugees and can't speak the language and are low socioeconomic status, that is an inappropriate character of the community. It's a highly literate community, and one where just language accommodations are not sufficient. In terms of religiosity, again, I don't want to belabor this, but you know that the majority of Muslims and globally are Sunnis, same thing in the United States. And you see here the comparatives are that Muslim Americans, and I always start off with using these demographics for the non-Muslim audience because they need to understand that this population is more religious than the general US population. So nearly 70% say religion is a very important part of their life. 2/3 report praying daily. At least half attend the mosque weekly, right? right? So I think the number is 48%, the actual number, compared to a third of the United States population, and that's for several reasons. Obviously, we know it's because of Jummah, but it's also because of other mosque activities, which we'll get into in a second. So I said we're trying for known knowns, right? So what's the known about Muslim health outcomes in the United States? What's known about that? Well, what's known is that's unknown. I'll say that again. What's known about Muslim American health outcomes in the United States is that it's an unknown. It's an unknown entity. Why? Well, this is one example of a study I did with I'm sorry for the question marks. I think there was some issue when we moved from my laptop to Google and back. But a mentee of mine a long time ago, we did a study, and we wanted to see what is known in PubMed, so Medline literature around Muslim American disparities, and we did this literature search. We just put these search terms on in PubMed with their explosion mesh headings, subheadings. Found 2 articles at that time, right, in 2009, so 11 years ago. And then when you added disparities, not just health disparity, you got 10 articles. So the idea that in the external literature, right, the peer-reviewed literature, the academic literature, the health literature, this was the sum total of what we knew about Muslim American health disparities. So that's the idea. That's a known unknown, but we don't know much about it. And you'll find, and if you delve into those, I'll share with you later on, that you'll find that most of those papers that are out there, even now, today, still today, 11 years, 12 years on, that these are papers on local projects, right? They're based on community samples, and they therefore present a non-comprehensive distorted picture. For those who like Islamic studies, I often use this analogy, that it's like you're trying to get the Sunnah, right, which is a sum total of the living doings, the tacit approvals of Rasulullah Sallallahu Alaihi Wasallam, from one partial hadith, which has a questionable narrator. You would not juridically, right, say that this is the basis of the Sunnah if you just found one piece of evidence. And so we can't do the same thing for American Muslims either. Unfortunately, we have this flawed data. Why? Well, the answer to that is that it's very difficult to get at Muslim Americans. So I've said here, finding Muslim Americans. What I mean by that is if you look at the national databases of the United States, almost none of them, actually none of them, by law, have religious affiliation captured within them. Sierra's cancer database, NHIS is National Health Interview Survey, and NMC's is for ambulatory care admissions, ER, and so on and so forth. None of them have religion as a category. So if you're going to look at a religious population and you want to see how their health aggregates around that religious affiliation, you can't do it from these databases. If you want to try to get Muslims in these databases, you could use names. Some databases like Bouquet Blue Shield and others have name algorithms. Obviously, you can get names of patients if you get the appropriate clearance ethically and legally. But then these naming algorithms have poor specificity. So if you're going to say, okay, I'm going to use, I don't know, Abdullah even as a naming algorithm to get Muslim Americans, most of these are problematic because you only have low specificity for the entire population, right? So you might have a certain name aggregate within one certain part of the population, but not the overall. Therefore, maybe Muhammad you could try with the same issue there, right? That you'll have a partial view of the population, it'll be skewed sample. I mentioned to you that there's regional local projects, but the problem is that those projects are based on, as you know, minimal community infrastructure. So oftentimes data collection is poor or absent, and therefore you can't generate any generalizable knowledge from that work, which is going to be part and parcel of a problem for our project here. That should we want to generalize our knowledge, we have to make sure that we do data collection in an appropriate way, which we'll get into later on. Lastly, you all know this as well, when we talk about Muslim American health, we want to actually talk about Islamic influences on health. This switch is not an easy thing to do as a researcher, because we can certainly say Muslim is a social category that people are self-identified towards. But if you want to understand Islamic influence on health, then we need to be assessing Islamic. And that means we have to have really fine-tuned and nuanced religiosity measures. And these don't exist either in the literature. So a lot of, you'll get a sense from me that I have a little bit of a jaded view on research, but also a realism here, right? That when we want to say, or specificity, when we want to say something about Islam, then let's talk about Islam. Right? If you want to talk about Muslims, let's talk about Muslims. I don't like to conflate those two, neither in the Muslim health work nor in the Islamic bioethics work. And I'm not sure if you all see why the question marks are here in the slide set. I think all my arrows have turned into question marks, unfortunately. So my apologies for that. But in terms of studying Muslim American health disparities, that's ACD, right? I did the study that I mentioned with my mentee, Afra, and we kind of tried to use the ethnic, social, ethnic, racial, and geographic proxies. We added Arab Americans, South Asian American. We added sort of Muslim majority nations to that. And you still see here the problem was at that time, 11 years ago, there were very few studies, 171 over a span of 30 years, mostly amongst Arabs and South Asians, right? The problem is that when you look at Arab population, more Arabs in the United States are non-Muslim than Muslim. More South Asians are non-Muslim than Muslim. So to generate data about Muslims from a ethnic sample was really problematic. Moreover, these studies did not actually include velocity measures, right? Which is my point. So if you want to differentiate what Islamic influences are, yet you're going to use an Arab or a South Asian population, and then also not include velocity measures, then you can make no assertions about what's happening amongst Americans. That is true, that we couldn't do anything. Or not that we couldn't, but the studies didn't do anything about that. Now, for an observer, not in the community, they would say, okay, well, either, what would be the hypotheses? Either it's not important, so no one wants to look at it. Meaning, if the people who are doing the research from the community themselves don't believe religion is important, then why should we as an observer look at it? Right? If this is the sum total of the work out there, then perhaps there are other influences that are more important. You could assume that. Or you could assume that the people, because most of these studies were done by community members, right? Or so you're assuming that they have some tacit knowledge that you don't, which is why religion is not looked at. Or that there are insurmountable challenges doing religion or faith-based or health work. Only two. Maybe there's another you can tell me later in the Q&A. Now, this is also old, and I'm dating myself. It was 18 years ago. This was a great paper by Robert Mentrimo in Social Science and Medicine, when they talk about this category of health disparities and health inequities. The field has moved on, but I want to point out two things here, and I've highlighted them. So traditionally, just thinking conceptually, health disparities are differences amongst populations based on differences in health status, being what your health status is presently, or medical treatment, which I would meaning what happens in the healthcare system or what happens outside of. Right? There are differences in population again that are related to their health, their overall health, part of which is dependent upon the healthcare system. So it's either related to the health status or what happens in the hospital, the medical treatment they receive, right? That portion of their health care, so health or health care. Then that's the first aspect. The second aspect is that the idea when we say disparities and inequities, we think that there is something objectionable about that. So the first thing is an empirical question that I can measure a difference in health status. How are people in Utah compared to Nevada? How do people who go to the hospital at the University of Chicago compared to those who go to UIC? It's an empirical question. I need to design the study, but I can get to that. The question is, how do I make a normative assessment? Something is unfair or it's avoidable. Right? How can I find or determine that that difference is unfair, because then it's a disparity, and it's avoidable? So oftentimes when you read all these these glosses around health disparities, we focus on the empirical question, which is appropriate. But as a bioethicist, I'll say that we also should focus on what is the normative component, what it truly is unfair, and why do we think it's unfair? What is avoidable, and how are we sure it's avoidable? I'll give you an example before we move on. Actually, it's coming on the next slide. So let me show you this. This is just blowing that up here, right? This is from RWJ, Robert Johnson Foundation, where they have this idea of, we want to look at quality of care. So this is healthcare system related disparities, right? between minorities and non-minorities, and we want to look at the difference. That's the empirical question. On the right side is, what is that difference related to? Is it based on objectionable things like discrimination, which is a disparity, or the healthcare system and this regulation? That's a disparity. They're objectionable things. The red here is the dissimilarity, right? Is it because of dissimilar access to care, appropriateness, and need, or patient preferences? I have made that red because that's where the normative assessment comes. So let me give you an example. This is from my days as a biomedical engineer and undergraduate at the University of Rochester. We were studying the failure rates of knee replacements. Okay, so there's a standard model. I forgot the company name now, but there's a standard knee that you can get at that time. Now, I won't tell you how many years ago, but many years ago. And we noticed that it failed amongst certain populations more than others. And we found that it failed amongst Japanese people and Arabs more than it did other populations. So the question was, why? Right? And the research would suggest it's because these people use their knees more often. Japanese people like to sit on the floor and bend their knees. Muslims would pray. So our hypothesis was because of that. But the question is this a problem? Is it an objectionable failure rate? Should the entire market now be based on a different knee model? Because the model that they had was, and the stress forces that they had created, that had investigated to create the implement, the knee, was based on the majority population, which was not Japanese nor Arab. So is that a problem? Is that a normative assessment that we've created a disparity in knee failure rates amongst Japanese and Arabs, and that's objectionable? So that's what I mean, the normative assessment, right? You could say there's high failure rates, but am I supposed to make a specific knee for every single group? Is that what's supposed to happen? The company would say. How could it be in business? I gotta create something that meets most of the population's needs. So if you look at it, it does. Less than 2% of less than 1% of the population is Japanese, and less than 2% is Arab. 98% are fine. All right, so you see my point. Or you might say here, on a Muslim example, patient preferences. Muslim Americans don't want to see providers from the opposite sex. That leads to delays in cancer screening. Is this objectionable? It's a patient preference. You could have gone to the hospital, you didn't want to have a man or you didn't want to have a female, and therefore you decided that I want to wait. You waited, you got worse cancer. Is that our problem? Is it yours? So there are ethical normative assessments underneath all these sorts of things, which oftentimes are neglected to make that we don't make them explicit. All right, let me move forward. Let's take the slide, Vinny. I just want to tell you again, tracking healthcare disparities in the United States we do it by access to care. This is by legislation, access to care and quality of healthcare. That's the two domains in which the disparities are tracked nationally, which is good. But they're only done by race, ethnicity, or socioeconomic status. So you will see all those charts, right? We're talking about COVID-19, whites versus blacks versus Hispanic Latino versus indigenous, right? Native Americans or indigenous Americans. That's it. You won't be able to get data, and then also against, right, those who are living in sort of higher socioeconomic status and those are lower. That's it. You won't get anything further than that because that's how the legislation is set up, which creates challenges for us. So the question then becomes, so I told you about known knowns, right? So we knew that there was not much data, there's not much research. Now the question would be here, does Islam influence American Muslim health and health behaviors across race, ethnicity, socioeconomics, and geography? Right, that's the question. And I would assume that you would say yes, but what it is to the external observer, it's an unknown. You might say it's a known, an insider. Yeah, of course. But to them, it's an unknown. The question I've highlighted here is an unknown known, because it's, if you're saying as someone like me, I know it's a known, but it's an unknown known, meaning they don't know. So you have to decide which perspective you're taking, right? Again, it becomes confusing between what's known, unknown, and not unknown, depending on whose lens you're using. Nonetheless, I'm putting in this box of past implicit knowledge because I would say, and I would argue, and I'll show you data, that it is true that religion impacts health behaviors. The fact, however, is that the external community, the external Muslim healthcare system, or the health literature do not acknowledge that, or don't feel that the data that's out there is sufficient to say that there is this tie. So let me explain to you, not explain, let me give you some data from our own work, but I usually say that there's an explanatory model. There's several domains here where Islam comes to play. First is explanatory model, right? So that we know that, and some of this data is my own, that there is a God-centered view of healing within Muslim polity. That there are many actors here that many people would agree are actors and sources of healing, that there are many different means, right? Worship, medicine, herbs, and text-based practices, but there is a God-centered view that at the end, healing comes, right, as the hadith says, right? In Allah that Allah is not sent to a disease except for He is also sent as cure. So we all have this God-centered view of healing, more or less. A construction of health also exists, right? So there's this notion that spiritual failings might lead to physical illness. That if you have God-centered views, some people say, hey, that I didn't do this correctly, or I didn't do this thing correctly, or as I should have, and therefore I'm going to have retribution from God through illness, which might be, what's the word? Expiatory. Expiation, for instance. And the construction of disease is also based on religion, in a sense, right? So sometimes the notion of what is disease and what is not comes through a religious lens, right? Is pregnancy a blessing, or is it a disease? And if it's is cancer a fated thing that you have to, Allah wills who gets cancer, therefore I should be okay with it, or not? And when those constructions of health or disease meet with the healthcare system, you can get a sense of a clash of two different sort of views at times. And for those who are bean counters and empirically studying this, including myself, you can see that there are two worlds colliding, and that you have to understand, this is where the 3R model will come in that Fatima likes so much, where you have to understand how you refocus people's behaviors around health in a way that is religiously and theologically consonant, but acknowledges that there are multiple views on what is a blessing or disease. Islam comes in as an ethical legal framework, right? So we know, again here, and I don't want to go exhaustively, but from the research, you will know that certain behaviors are motivated and others restricted because of Islamic law, right? We don't drink alcohol by and large. Therefore, there might be some health benefits conveyed upon populations that are Muslim because of that, or different abortion practices, right? You might find higher levels of trisomy amongst the Muslim population. Is it because they're genetic risks, or is it because the fact that people keep their children and do not abort them if they have trisomy? And the way that you look at that, unless you have a holistic perspective, you might assume that there's some other problem, not one that they're accepting of children, this quote unquote, malady. Similarly here, now we're talking about flu vaccines. So you should all know flu block does not have porcine in it. And so when you go to your local Walgreens and you ask them what formulation they have, if you do, you might find some Muslim populations won't accept some that have porcine gelatin in them, and then therefore you might say that they're not getting vaccinated. But then they're not getting vaccinated because of religious exemption, because you haven't found them the vaccine that is religiously permissible. So again, this becomes a real interplay between religion, preference, and government sort of notions of what we provide, right, to patient populations. Lastly speaking, religion comes into play in terms of not a normative focus, but a social identity. Here, the idea that Muslim Americans are marked by a religious identity, and they are therefore prone to abuse and discrimination based on that religious identity, which then might contribute to health effects and impacts. Right. So on one hand, it might lead to more distress and low levels of happiness. Everywhere you can talk, Muslims and mental health has been a linkage used both by within the community and outside of, and I'll get into why later on, should I have time, why I think there's a caricature issue there. But secondarily, it might lead to people then having maladaptive behaviors, right? So you might have this linkage because of the poor adaptation that they have to this climate, avoiding healthcare or social isolation or stress-related illnesses. There's a paper that I'm a group of authors with on in Somali populations after the Trump ban, which will highlight this as well. Okay, so now, speeding through before we take Q&A, the question for us then becomes, where would you find Muslim Americans? Right? So if I am, again, the known is that we don't know much about their health outcomes, yet we think that religion plays a role in their health behaviors. So you and I are going to embark on a study to find Muslim Americans. So where would you find them? And if you're like me, I think there are only two places you would find Muslim Americans to study. One would be at a restaurant eating, right? We like to eat, maybe not now in COVID time, but you'll find them on Divan in Chicago, right? And mosques, or you might find them in a mosque. Right? I mean, I think those are the two places. If you want to do health studies, so many years ago, Chicago Department of Public Health was doing research on healthy lifestyles amongst, in their mind, South Asian populations, a proportion of which were Muslim, a significant proportion. And they were working with several Divan establishments to do that. And one of the big objectives that they had was to try to get all the stores, all the restaurants on Divan Avenue to have menus that declared the sort of the content, the calories of what they're feeding people. And you will know whether that succeeded if you were to go to Divan. Don't go to Divan now, but in COVID time, but that was not a great success for many reasons. But you see, this is where they said, hey, they're eating poorly. We got to fix that by going to these stores, and it's a challenge. Similarly, when you go to the Muslim sort of mosques, similar challenge around health. So let me sort of say that that I, obviously my work, and I'm biased here, that my work is centered on the mosque community. And I think this is a very important context for health outcomes research among Muslim Americans for several reasons. One is that we know that in mosques, we can sort of isolate the influence of religion across race, ethnicity, right? Mosques, some of them are very homogenous with a certain population, racially and ethnically. Others are very heterogeneous. And therefore, the way you select different, by the means of selecting different masajid, you can compare them, right? I want to see how the African American population is doing versus South Asian versus the Arab. Or you can say, no, I want to go to mixed mosques and then do the same work, right, amongst those populations there. So there's a good way to test. You can at least have the hypothesis: does religion impact cross race and ethnicity? Similarly, you can do the same thing around suburban and urban, right, mosques, or Sunni and Shia. So the idea is, by selecting different mosques in a sampling frame, you can tease out different influences of race, ethnicity, socioeconomics, urban geography versus suburban, and even religious influences. The masjid is a central part of Muslim life, at least in America, right? Where, as I mentioned, 48 to 50% attend mosques weekly. Now, this idea is not just masajid or the musalla, but rather the environment of the mosque, right? So you might go there for the food bank that's there, or for the Islamic school that's there, or for the social circle that's there, or for the educational event that's there. That the Muslim American community aggregates around the masjid for educational, social, health, as well as religious functions. They all come together. So it's a really fruitful site there. It's a site for identity formation, and the idea here is that if you're going to study how religion impacts health, this is where religion meets health, potentially. And there's some code speak there, MTC, normative beliefs. We can talk about that later. Lastly, so the way I want you to think about it is that the mosque community is actually a social network. Right? It's not a social engine, but it's a social network that's centered around a physical plant, but that physical plant has multiple ancillary institutions. And nowadays, obviously in COVID, that physical plant has a virtual footprint as well. So therefore, the community that can attend a mosque, the people that are influenced by a mosque is the mosque community. And there can be many, many, many more fold than just those who attend the masjid for Jummah, right? Through all the activities that aggregate around the masjid. Is that clear? Okay, so I typically like more interaction, but this form is quite a little odd. So this slide here kind of is trying to now think about the mosque community and how that relates to a patient-centered perspective, Victoria language, right? So these are the things that we can think about, that all these social determinants of health, right, can be addressed or can be present within the mosque community. And the things here sort of show you, I mean, the slide set shows you how the social community context can be related to religion, how economic factors, right? We share those data around Muslim Americans who earn less than 30,000. And the idea of healthcare access to health literacy, if you look at a population of new immigrants who come to the mosque, they might be, struggling with these aspects. So again, a way to think about the aggregation of these multiple dimensions of social determinants of health that can be present within mosque communities. All right. Yeah. So I'm not sure, the slide set is not showing up exactly how I want it, but nonetheless, let's proceed as it is. So these are sort of questions for you, but it looks like the answer is already there. so I can't really, it's not staggered as I'd wanted to do. And again, I apologize. So the question here, really, I was going to ask you all to chime in on, as opposed to my speaking all the time, was, what is the present culture of health in masajid? So I'll still ask that question. You guys can unmute or open in your chat. What do you think the state of the culture of health is in masjids right now? What is health informing in the masjid right now? Or in your masjid? Again, you can chat, you can speak. You can stay silent. I have no problem with silence.
I can share. Welcome everyone. This is Meher. I think we discussed this a little bit, maybe, sometime last week during our presentations. But I belong to the Islamic Center of Naperville. That's the mosque that I go to most frequently. And just an example of promotion of health and well-being there was I shared when I was in high school. They had mental health discussions, primarily for teenagers, led by young professionals in the field. And most recently, my cousin, who's a psychiatrist, also did like a virtual Zoom event for our masjid for people to tune into. And then I think someone else also shared that there's always a really big sports program. People stay behind and play basketball or playing sports together. So it feels like, especially with young people, of course, that's the crowd that I interact with the most. There tends to be a sense of community rooted in health and wellness and wanting it to be a holistic experience.
Thank you for sharing that. Yeah, I think that's a great idea here, that there are existing activities in masjids that can be health informing. Exactly what you're saying, with your example of the educational work that you were participating in. But also then there are activities which have health impact by their nature, like you said, sports or whatever else is happening, right? So there's at least two domains: health educational aspects and then health forming aspects. I mean, the thing that I have here on the bottom is sort of, the next bullet point, that my gaze, and it's not extensive or universal, is that most of what happens in masjids in terms of health formally are these screening activities. That what occurs in masjids are faith-based healthcare activities, meaning that we might have after Jummah, a blood pressure check or diabetes check. That we might have as a mental health aid first aid sort of function, where the idea is you want to get imams to be an extension of the healthcare system, so they can keep an eye on people who are not keep an eye on, but they can refer people who might have mental health issues to mental health professionals. And what we have is a gaze of just extending the arm, so to speak, of the healthcare system and the way it exists into a different space, and that space would be the masjid. So again, my critical view of that's a good thing, right, for people who don't have access. But if 87% of Muslim Americans are literate in English, and in my own work, 90+% have access to a physician, and then what is are we really addressing the challenge? If the challenge is in healthcare access, then extending the arm or the reach of the healthcare system may or may not prove effective. And if the issue is of religion, then these activities which do not, by their own nature, encounter religion, right, that they don't engage with religion, that they will also then be ineffective as health education modalities. So I'll give you an example. I have an uncle who's a brittle diabetic, and if I were to ask him, why do you eat in certain ways, perhaps sometimes, or you maybe miss your doses of medication, I'm sure, I'm in a certain way, he would say, that what's going to happen to me is going to happen to me, right? God controls disease. Are you telling me to put more faith in the medication or in God? Now, that might be a response that might not be fully accurate theologically or whatever, but I'm sure you have the similar experiences. That it's not that they don't know you should take the diabetic medication or you shouldn't eat that way. They don't. So now bringing in the education that, hey, you should be checking your A1C and you should be eating this and eating that is not a gap of I don't know. It's a gap I am not sufficiently motivated enough to follow this course of action. And I think that the problem, now this is me speaking, and not sort of database, is that the problem is that this is the modality that we have taken in our masjids. It's just a extension. That's controversial, I'm saying. We can talk about that in Q&A. But then the other idea here that, of course, of the imam's role, so these two studies on the right, these are a study that I did, again, many years ago, and we did a study of asking what the role of imams were in terms of, in the Muslim American health, and we found that these are 4 aspects in which the imam plays an essential role. Right, so the imam gives khutbahs, which may or may not be health informing, or he provides sort of religious rituals around death and dying and birth and marriage. Right, so the performing of rituals and these functions is a health informing activity. The imam might provide cultural sensitivity training, so they might be called by a healthcare system, right? Oh, I don't understand this patient, needs this or that, the other thing. So can you help them as a bioethics consultant, or can you give us an understanding why they're acting this way? So they provide this dual role as a liaison from the community and the religion to the healthcare system. So we found these are the 4 themes that came up in our interviews that imams play. Now I'll show you in other slides, or maybe in the next talk, not today, how we leverage these in some of our research. Actually, not next time, next slide. So here you go, right? Turning this idea of this is the role of the imam in our work, that we wanted to also say, okay, let's talk about sermons, right? So you'll hear, and I'm sure this month is one where you'll hear many sermons on 2 things: domestic violence and on breast cancer, right? October is Domestic Violence Awareness Month, and it's also breast cancer screening or breast cancer awareness month. And if you're in a very forward-looking masjid, you might hear some khutbahs on that, or you might hear your favorite scholar talk about that. So we wanted to test in an empirical way whether the Jum'ah khutbah was a modality for health promotion education. Did people who attended masjids feel that this was acceptable to either leverage, right, capitalize upon the Jum'ah khutbah, or to some, right, to usurp the Jum'ah khutbah as a modality for health promotion education. We did this through surveys and interviews. I'm presenting to you the survey data. Interview data needs some work to finish out, but let me give you the content here. So the khutbahs had 4 main themes, right? That we used 2 masjids and 3 sermon activities, and we delivered these 4 messages with a scripted khutbah that had bullet points and had hadith to back up and Quranic ayat to back up these ideas. One was good health is a grant from God, right? That's simply it. That good health is a grant from God. You should be thankful for it. You should be grateful for it. You should recognize where it comes from. And the body is a trust that you'll be asked about on the day of judgment. That it is something you're responsible for, like everything else that God gives you as an amana. That tawakkul, trusting in Allah subhanahu wa ta'ala, does not mean I'm not taking any medication. That the fuqaha have discussed this ad nauseum, and there's many examples where this does not mean that you just let go of all quote-unquote worldly measures because you want to rely on Allah subhanahu wa ta'ala. And then lastly, the community members are caretakers of one another, right? Right? That they are protectors and caretakers of one another. So this was the 4 messages, right? So we didn't talk about God wants you to have mammogram or whatever else it is, but these are just general ideas, and we want to see if people felt this acceptable. So this is the result from the survey in the paper. So 235 people took this survey after 3 masjid sessions, 3 khutbahs by 3 different people. You'll see here that in terms of what do they think of the sermon, you found most people were felt right. It's 4 to 5 out of a 4.5 for scale. Was it acceptable? Nearly 90% felt it was acceptable. It agreed with the idea it was acceptable. Was it relevant? Again, right? Nearly 90%. They learned something new. Again, right? Now, would they like to see more topics about health? Okay. Still, you see on this end, the imam. Now, this is more about the imam, so it's not really relevant here. So you saw there was broad acceptability, agreed or somewhat agreed with the idea that the sermon content was relevant. They learned something new and they found it acceptable. And then we asked them, right, how likely, this is important, as I mentioned to you, that the Muslim community, the masjid community is a community, not just those who go to the sermon, right? So we asked them, how likely will you talk to people about this in your family or wherever you meet? And you saw again, like nearly 80% were going to talk to someone else about the message they received in the khutbah. So your catchment your impact is significant, right? 235 people, even if they talk to one person more about it, then that's 500 people, right? And so you can imagine that the spreading is high. Then we want to just test them. We're going to see, okay, do you remember what was told? Right, this is right after. So pre-post, bottom of this is pre-post, immediate pre-post, yeah? So khutbah given right after. What's the mean? 70%. The community got a C. We just gave the khutbah and we asked you, did you listen to the khutbah? What did you learn? Or you remember knowledge test? 70%. Which should give you some pause, right? To how much people are actually paying attention to the khutbah. Nonetheless, right? I think C is passable, but as an academic, we expect more. Hey. All right. Then the next part of the study was to think about, all right, well, is the acceptability and all this stuff vary by race, ethnicity, or gender, right? And you saw here in this slide, so you see here that the p-values are greater than 0.05 or even 0.10. No difference by male, females. Both populations felt acceptable. No difference by South Asian or Arabs or whatever else it is. What you found here in terms of acceptability of sermon giver, which is interesting, I'll share with you. So we have 3 masjids here. Those in Chicago know these MEC, where that is, right? You know where OPPC is, Orland Prayer Park Center. So there was no really issue with acceptability, but in terms of the sermon giver, you saw here, I'm the one who gave that sermon, so they didn't like me as much as they like their moms. It's good, right? That's fine. So you might want to just generalize the knowledge here is that all these guest khatibs who come in and try to talk to the community. Perhaps that's not the best way to go when you're trying to give health sermon. You probably want to use someone who they already have established relationship with. All right. So we're now almost near the end, as I told you. We're going to do some Q&A, and then inshallah we'll break from all of it. I want to kind of forecast where we're going. So I shared with you what the mosque community is. It's a social network of the mosque, which is a physical plant, and ancillary institutions, and that the effect, the impact is a larger community than just those who attend the musalla. But we're going to leverage that in terms of thinking about mosque peak or stakeholders. Stakeholders that are within the masjid community that are relevant for patient-centered outcomes research. This is on the right-hand side of the slide. These categories are the ones that PCORI, the institute itself, thinks about as the 9 stakeholder groups. And we will discuss this slide a little bit next time. It's in your training kit and manual about where we might find who is primary, who's secondary within the masjid. I'll say, actually, let me just say it now. So I hope that Dr. Rebecca and Fatima spend some time on this. But when you talk about patient-centered care, it's patient-centered, but we also know that it's relying on the idea that they're caregivers, right? Caregivers are not just physicians. So PCORI talks about caregivers as it could be your sister who's in the house taking care of you when you're an extremis, or the paid caregiver, right, who comes, the visiting nurse who comes. So patients and caregivers are at the core. Then you move to clinicians. So the primary role here are physicians, right, and healthcare providers, right, and we will also say researchers. Then after that becomes the healthcare system in general, payers and healthcare system, hospitals. After that becomes sort of like those who purchase the health plans, and so there's the way PCORI thinks about it, there's a certain sort of overlappingness to some of these categories, but also the core is here, and I wanted to point out the core is patients and caregivers, not patients and doctors. And in the masjid, you would think about this could be the health clinic, right? That's in between the core and the primary, because there are clinics attached to masjids. In terms of payers, and there are a lot of physicians, so again, primary. So you would find a lot of people related to these 2 circles in the masjid. Everybody's a patient or a caregiver, a lot of physicians and health clinics. The second and third tier, there are maybe less of, or you might have to work harder to find those people. Who are the policymakers or the purchasers who work at those sort of companies, or those who run healthcare systems, right? It might take you some work to figure that out. Okay, and then lastly, we're going to move to boss stakeholders, and we're going to move to sort of engagement principles, and these are the 4 principles, and the link is here on the slide set from PCORI around what they think about engagement, right? How they view engagement. So you, as a researcher, or the liaison between the researcher and the community, are going to adopt these principles as you go into your role as a community health worker, right? The idea that there should be reciprocity in the relationship, right? That now these are ideals. They're not in effect in every project, but the ideal is that there would be co-shared decision making. Decision making is collaborative, and this reciprocal relationship there, so that you are not just I am the person who knows everything and you are the person who needs everything, but rather there's a reciprocity there. Again, both in terms of power, decision making authority, but also in terms of learning. That we, as I said, we're moving known knowns or unknown knowns to the known known. So for the external observer, the unknown known is that religion plays a role. But how does religion play a role? I don't know. None of us know. It's both an unknown unknown. So to do that work in PCORI, that means I have to partner with someone who understands the community, who understands how religion plays a role. Then I can make that a known known. Partnership, right? So everything should be partnered. And then transparency, honesty, and trust. We've lumped them together. They're separate ones. But the idea that there is this notion that you're going to be transparent about decisions that are being made, about things that need to be done, about ideas, be honest and trust, and trust each other and try to convey trust. So those things are what PCORI wants to hold out as engagement principles. And there's also engagement rubrics. We can talk about that next time. I'm going to kind of skip over the slide, but you'll see it again next time. And lastly, I wanted to remind you all that you, inshallah, will be dealing with mosque communities, right? So these are what Fatima tells me are the 6 mosque communities that you all will be assigned to. And so you all will be working together to bring sort of a culture of health within these masjids and to elicit the unknown knowns to make them known. And that's it. Okay, but we have several minutes for conversation. I'm going to stop sharing my slides. This is your time.
Dr. Patel, I have a question regarding the chart that you showed about the sermons and the engagement of the crowd within those khutbahs. Have we come up with any kind of strategies as to how or what works best to engage them better in those khutbahs regarding these health issues or health culture to be promoted?
So I'm not quite sure what do you mean, how you engage them. What do you mean by engage them?
Well, I thought the chart showed that there was a lack of attention to the khutbah. So before and after the khutbahs, the results showed that people were really not paying attention. They didn't remember what the khutbah was all about, or there was a trust level that wasn't there from the guest khatib to the information that was presented to them.
Yeah.
Is there any way to get them more engaged, where they're more actively listening?
I mean, so you would have several hypotheses, right? I showed you one speculative hypothesis. You could say that people scored a C, a 70 out of 100, so to speak, because everything was new. It was a hard test. One could say the test is too hard. One could say that the knowledge was too new, so there's so many new things that they couldn't hang on to all the new things. Or one could say that they potentially, right? They may hypothesis, or one could say that perhaps they were not as attentive. And so I hung on the idea they're not as attentive, knowing what I know of Masjid Khutbahs. Sometimes people sitting in the back, falling asleep, right, on their phone, not paying attention, daydreaming. I mean, I'm hypothesizing. It could have been I made a very hard test. I don't know. But how do you change that? That's not going to be changing you and I change that. It's not going to be the healthcare worker that changes that. That notion is just a reality. You have to recognize that you have to deliver content in a certain way to make it engaging, right? So you can certainly make it engaging by delivering it in a better, more effective way in small bite-sized chunks. But also that not everything everyone will understand. So you probably don't want to bury 15 facts about cancer screening in the middle of a khutbah, right? If I start talking about this age, this population, this test, those are too many facts to embed in. So we just gave general concepts and ideas. So I suggest that the khutbah is for that, general concepts and ideas, and then you should have a follow-up activity, perhaps, that people can concretize knowledge that are factoids. And I see some masjid that give like a sort of Jummah khutbah guide after Jummah khutbahs. I don't know. Maybe that's another way to make it better. One of our friendly imams, Fatima, does this all the time. And I think you know who I'm speaking about.
Actually, that was a question I wanted to ask. Following on is when you're thinking about a sermon, are there rules? Are there ways that you have to present material? Can you include humor, for example, or is there a protocol, or could you actually do whatever you want to do?
Yeah, I think that's there's two aspects there. So I can answer both religiously and culturally. The easier one is to think religiously that there are certain aspects of a sermon that have to be met for it to be considered valid. And so you have to make sure that those components are there, right? That are praise to the gods, some salutation of the prophet, some recitation of the Quran. I mean, there's certain things that you could do it in 15 seconds, right? To make sure those things are met. As far as the content, now it's really dependent upon the masjid itself and their style, right? Mm-hmm. Some mosques do not like to talk about worldly, quote unquote, matters. They want to talk about spiritual matters. Right? Yeah. So going in there and talking about XYZ would not, or cancer screening, for example, might not be the best way to go about it. Mm. People might get upset. Other mosques are different. Some mosques, they only have the local imam is the only one who gives sermons. There's no guest speakers, right? So you have to think about it in many different ways. I'll tell you two tidbits from often the study I presented. One tidbit was when we were interviewing imams and others about the role of the imam. That study I presented here. I remember this quote many, many years after, where someone was saying, right, it's okay if you tell our population that they should get a mammogram and cancer is a bad thing, right? But don't you dare say God wants you to have a mammogram. Right? Something to that extent. The idea that the utilization of religious vernacular and obligations and shoulds and shouldn'ts is not something that we should take lightly. And you can't, on sitting as a sermon giver, utilize religion for that health end. I mean, you can tell them about all you want to tell them about. You can't say you'll find God's pleasure in this activity. And this came up. That was many years ago. This came up in 9/11, not 9/11, in the healthcare reform, Obamacare aspect as well, where there were a lot of Muslim health organizations that wanted, and they created schemas for sermons to get Muslim Americans to be promoting healthcare reform and Obamacare. People do that for actually even elections. And there's a big problem there, right? So for example, Obamacare, I've written on this in the paper, Rebecca, I can share it with you, but Obamacare is an insurance schema that is considered religiously prohibited except for in extenuating circumstances are you allowed to purchase insurance.
Yeah.
So why would you get on the pulpit and say you must all sign up for Obamacare?
Yeah. Okay.
You're telling everybody to go towards a sinful activity, according to some. So I don't like the idea of sermons being utilized willy-nilly. I think you have to very, cogent message, and you must check it with those who have religious knowledge, whether the lingo that's being used.
Thank you.
There are a couple questions on. Is that good? Yeah. There are a couple questions on the chat that I see here. So it's on different screens. That's what I'm looking up here. Andy asks, with all the current bans, are folks more reluctant to participate in research recently? And then also, how are you engaging a younger generation versus old generation for the sermons? Well, we didn't do. You saw here the analysis by gender and race ethnicity. All right, we didn't actually do any analysis by age, so I won't speak in a data-driven way around something I don't have data on. Obviously, those who give sermons know that you have to communicate with different populations differently, so that would come in here as well. And as far as the first question about bans, again, there are not that many people coming to masjids now, right? So therefore, to have the masjid as a locus of research activity, prospective research activity, might be challenging because there are not as many people there, and so your sample might be smaller or it might be skewed in a certain way. I think even IRBs might find it problematic for you to go into mosques right now for a non-health impactful activity, right? I mean, why are we doing research that's not as important to life and death by doing stuff in masjid? So I think it might be a little challenging. Yes, Rebecca, that's an area of active interest and work. Anybody else? We have like 5 minutes or so.
Yeah. So from the presentation, it hit me that first of all, the difference you're making about Islam and culture, Muslim culture, is a really big thing, and like this whole thing with like using sermons and stuff like that. So I guess this is would you say one of the struggles that we're facing right now is how to, after identifying the problems, which I think already might be much easier, like how to implement interventions to kind of connect everyone, because we can't use a lot of the things that are already out there, it feels like, because of this cultural resistance against things. Because, like Islamically, we know that your body's an amana and you can explain that as much as you want, but then always there's cultural things that come into it. So like, I guess my question is like, I'm confused about which direction we have to go to kind of really effectively research things and like create programs.
Sorry, my browser crashed in the middle of that. So you're saying you're confused about the distinction between Islam and Muslims, and
No,
why I think that.
I do understand that, but it's like I'm confused about what direction we have to go to really research, because the disparities we can research, that's fairly straightforward, I feel like, but the interventions that we would come up with or the connections we would try to make, I feel like a lot of the current like programs to promote health, like for instance, Obamacare and insurance and stuff like that, comes into conflict. So
I don't think it comes into conflict. I was sort of saying you should be nuanced in what you're communicating in the sermons, right? Like we're beyond the elementary Islam 101 or health elementary 101. You should, right? Like I think that as a physician, I'm responsible for what I communicate. As a sermonizer, I should be professional about what I'm communicating there as well. As a teacher, I should be well. So I think that I'm trying to give you a sense of the professionalization of what we're saying, the precision of with which we have to deploy messages. As far as the idea that it's easy, I don't think it's easy to distinguish what is an Islamic influence or not. I think you have to develop measures. So Fatima will tell you that for our breast cancer work, we developed a measure around modesty, a Muslim measure of modesty that didn't exist in literature, just like there's a Jewish measure of modesty, right? We created a Muslim measure of modesty, and we found that there was no relationship between modesty and breast cancer screening amongst Muslim Americans in Chicagoland. And we have to explain that finding, because people would assume that that is the case. Or people might even write as experts that's the case, but it's not based on data. Because the data would say, the only data that would say, the ones from us, was there's no relationship. That is the only data that's out there. And so I think, but to make that claim, we have to develop the measure, then use the measure amongst different populations and see whether the measure is good, and then see if that measure has any relationship with breast cancer screening. So the road is long, is all I'm saying. But if you don't do that work, what you have are talking heads and sort of, yeah, I think, and which might be true. It might be a known, right, an unknown known, right, from the perspective of the community. Then make it explicit. Do the work to show that it is the case. So I'm not down or pessimistic about the possibilities of doing this sort of work. I'm just saying we have to do the work. And that's all. And if you're all on the boat to do the work, then alhamdulillah, may Allah bless you. If you're not, then recognize that you can't go about using sermons, which a lot of people do, willy-nilly. And we can't make claims about data that we don't know anything about. So we have to be responsible. I hope that clarifies.
Yeah. It does. It clarified a lot. Thank you. Okay.
So, Dr. Badina, in a nutshell, what you're saying is that we should be using the sermons to educate the Muslim community that comes there, but this education for the sermons has to be data directed.
I'm saying I'm not one for, let me just say that, yeah, I think that the sermon, if you're asking me as an expert in Muslim American health, what we should be using sermons for, I think it would be for general messages that have to do with the religion and the relationship with health. They're general, right? So there are not too many factors. And that we should do in a way that they are not making prescriptions or prescriptions. So we're not proscribing, right? Like condemning something, or prescribing something specific without recognizing the religious valence of that. And by that, I mean the ethical stance of that action within Islamic law. That's what I'm saying. I think that it's a great forum for communicating general ideas and to discussing certain things, but I think it's overused at times for health purposes. And yet it has power, as I showed you in the data, that people talk about that with others. And so it has a huge catchment if done correctly, but also if done poorly, right? So just take the other side. So if you said everybody who's 40 should get mammography, and you're the expert in that, and you did that on the sermon, in the part of the sermon, someone remembers that, how many false positive tests would you prove? You have told the wrong guideline, and you had a lot of people who are scared about themselves, right? Like, I mean, that's what I'm saying. Like, just respect the forum. And I think that if the data speaks to the fact that imams from the local community should be ones giving a buzz, then perhaps they'll know. So in your projects, for all the community health workers, no one's saying that you go give sermons. It's not part of the grant. You all don't have to go do that. Don't worry about that. Maybe you want to make a sermon guide, fine, but no one's mandating you go do that. You should.
So, are you do you think there is a need for having a program out there that could actually perhaps like a sermon guide education program for health equity or something like that?
That's an excellent idea, Fatima.
Now, don't put that into me in charge of that project. Please
That's
don't.
You actually got a grant on that. Let's see. No, that's a great idea. But
And what about there are imams and there are khatibs? So there are a lot, especially a lot of the MSAs and the younger generation that are. There was a question, by the way, about the yeah, but you did say that there is not, you don't have the data on that. But what about the khatibs that are younger, of the younger generations, and especially with the MSAs? There's a lot of the messaging that goes around. What's your advice to that groups or those groups?
Well, I think that the MSAs are not part of the Muslim community, right? So when we're talking about the mosque communities, that's a different dynamic, different concerns. So I would want us to recognize that first. That we're talking about the Muslim community around a mosque, not just the MSA thing. As far as using the modality of sermons, I mean, I think you certainly can have conversations around the healthy and risky behaviors within the context of MSAs. And issues that Muslim students face there. I think that's appropriate to do. Would that be best given by a student themselves? Not quite sure. Perhaps. So I can't really speak to that. I think that each, as they're saying, that each unique context, you have to think very carefully about who is the best messenger and what is the best message. So that will then lead to different valence of the message with the people who are in the audience. So any last sort of questions from the from the cohort? Dr. Johnson and Dr. Fatima have access to me all the time. Sometimes too much access to me. So you guys don't have as much. So any questions for you all before we break and we go to Maghrib and whatnot?
Brother Abdurrahman asked a question in the chat.
Okay, let me see. Hold on a second. So he asked about the other effective ways you can communicate with the community besides sermons. Yeah, so I mean, I think you'll see some of this in the next few sessions where we talk about educational workshops. So I think you can communicate. Each modality has a benefit, right? So complex communication can occur in the setting of a workshop that's dedicated to that. The general message can be delivered in a sermon. A snippet or factor could be delivered in a newsletter, right? And I think you have to think carefully about the modality and what can be learned from that, how that can be used in an effective way. And we have data to study. I mean, you can study that, see how well message is understood, or at least received in those modalities. So that's what I would say. I mean, you can also, like Factorize, you can deliver on Facebook. You can have a flyer. We're at Fatima and I finish Islam Mess. We're trying to make graphics and toolkits and sort of visual graphics that people can digest with just looking at the screen on a one-pager from studies. So I think that you can use these different modalities to communicate. There's an art and science to it. All right, so I'm going to see you all, inshallah ta'ala, in 5 days or something, 4 days, inshallah, for the next session. I'm going to close here if you permit, Fatima. Yeah, barakallahu feekum. May Allah bless you all, inshallah ta'ala, and we'll see you in a few days. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت نستغفرك ونتوب إليك. Assalamu alaikum.
Walaikum assalam. And guys, we will be having another session with Dr. Johnson tomorrow at 5 o'clock. Thank you, Dr. Johnson. Thank you, Dr. Thanks again, everybody.
Thank you.